So I want to thank Hassan and the committee for inviting me to talk here. I'm speaking as a user, not as a domain expert in graph databases. And I want to show you some of the things that we are working on in the healthcare domain. Oh, yeah, I'm gonna I guess this other, hey, can everybody hear me? I guess I have to talk louder. Okay, so why do we care about using graph databases in healthcare? Well, healthcare is delivered by networks. Networks of providers connected to each other by patients. The patients move through those networks, and our premise is that network topology influences outcomes. So we are very interested in looking at network topology as we can reconstruct it from healthcare events. Data in healthcare systems has a relatively simple format aside from all the attributes associated with it. Patient, provider, location, an event, and a time. And if you think about building a network with those fairly simple attributes, you can create a network that reflects how people move through the healthcare system, how elements of the healthcare system are connected to each other, and how an individual touches a healthcare system from everything from a provider visit to a hospitalization to visiting a pharmacy to outcomes. I'm going to show you 3 use cases. The first use case is modeling a hospital using a graph. So our basic data set is 209,000 emergency room visits and admissions. Basically every single admission or emergency room visit to the hospital that I work at over 2 years. And all of the locations that those individuals who had those visits ended up in the hospital, as well as their discharge dispositions or outcomes. I learned that our hospital has a special code for discharge to law enforcement. Who knew that we kept track of those kinds of things? And a large amount of associated data, including every single medication with a timestamp that an individual had during their hospitalization. We haven't even begun to mine that. So the first use case was intensive care unit readmissions. We were interested in looking at whether a readmission to an intensive care unit, so somebody comes into a hospital, they go to an intensive care unit, they get better, and then they return to the intensive care unit. So it's a loop in a path graph. And we were interested in seeing whether or not there were outcomes that were could be associated with simply the loops within the hospital. So the first thing we did was for all of those 209,000 admissions, we created path graphs. And then we used graph isomorphism to ask, forget about what part of the hospital the node stands for. Is the shape of all of those path graphs, are there common patterns? About 83% of the path of the graphs are linear. So people go from one area in the hospital to another area in the hospital to home. Most of them, over half of them, are emergency room, home, intensive care unit, death, or other outcomes. But you begin to see these loop outcomes, and actually fairly complex, and you get down to unicity, where you've got people who went to different areas in the hospital. This person looped between an intensive care unit and a step-down unit 5 times. What I like about these graphs is that when I show them to my medical colleagues who know nothing about graph theory or networks, they try and imagine where that person might have gone. Where is that? And some of my ICU colleagues say, wait, I think I took care of that person. Where are those nodes? So it takes a graph and it humanizes somebody. It uses data to allow people to put themselves in, uses graphs to allow people to put themselves in the footsteps of patients. So we noticed a number of fairly simple patterns: cyclic journeys, linear journeys, complex linear journeys where people had went to many areas in the hospital, complex cyclic journeys where people went from a medical floor to an intensive care unit to a lower acuity step-down unit back to the floor. Those journeys tended not to end very well in that they ended with death. So we looked at whether cyclic journeys were associated with patient outcomes. So we did some statistical modeling and we selected a group of patients that went to the intensive care unit and survived the intensive care unit stay. So that made them eligible to loop back. And then we looked at the survival of those patients over time. And what we found was, so this group of folks who died during their first intensive care unit admission were excluded from the analysis. But if you look at the course of linear journeys versus cyclic journeys over time, there was, even adjusted for illness and other factors, there was a very significant difference between the survival of those patients. So topology of patient journeys is a risk factor for survival. Now, the work that we're doing now is we're looking at all the possible predictive factors, because what we would like to do is come up with a relative risk index of somebody looping back, and then try and change that curve. Now, we started with that use case of graph isomorphism, but we then scaled up and we said, okay, can we model the entire hospital? Can we get an idea of where people are going and the linkage between the units in the hospital? And so essentially what we did was use the graph inspiration of trace route mapping of the internet, and we trace route mapped our hospital. We broke each of those patient journeys into dyads, where somebody went to location 1 and then location 2 in the hospital, and we summed up the occurrence of those dyadic pairs, those edges, and we know the time scale, and so we were able to create. I show this to non-graph savvy audiences to make the point that this is impossible to interpret, but so the hairball, but we were. I'll show you a better representation in a minute. We were able to look at hospital unit linkage and how patients traverse the network. So this is the heat map of an adjacency matrix. You'll notice it's not symmetric. These are patient discharges leaving the hospital. Because people don't come in from those discharge categories, this entire portion of the symmetric matrix is blank. These our units are grouped thematically, and immediately you can see that there are parts of the hospital units that do not transfer or receive patients from most of the other units in the hospital. So these are essentially isolated hospital communities, and they are the labor and delivery area, the psychiatric unit, this is the neonatal and pediatric intensive care units and pediatrics. This is most of the other adult hospital. This area are the intensive care units, and you can see that they tend to transfer patients a lot between each of the intensive care units. You look at this, and when I show this to hospital administrators, what they say is, well, that's because one intensive care unit is full, so we need to put somebody in an intensive care unit that may not, at that point, be appropriate for them, and then we transfer them back the next day. Now, people aren't packages, but as you all know, FedEx uses operations optimization algorithms to load balance their network. Hospital load balancing is done in an extraordinarily analog fashion. You get a bunch of people down in a room in the basement that's covered with whiteboards like this with how many patients are in each hospital unit, and they all figure out where they're going to try and put people that day. We started to use this model to also look at various scenarios. What happens if you close down one of the intensive care units, which is the plan if we got an Ebola case? We would put them in one of the intensive, where are the rest of the patients going to go? No predictive modeling like this is done, as far as I can tell, in terms of load balancing other hospitals. The other application for this is with these clusters, just like you would identify gene regulatory networks by areas, by genes that are connected to each other, we can create a feature vector signature of hospitals, and we can compare hospital topology across hospitals. So those are some of the derivative projects that we're working on for this. Now, this is not a very large graph, but it occurred to us that we could trace route map the healthcare system of the entire country, at least the government-funded portion, which is Medicare. For those of you from Europe, Medicare is a healthcare system here that covers people who are over age 65, as well as a couple of categories of folks with permanent disabilities, people with kidney disease who require dialysis, and people with neurologic disease. About 40 million Americans are insured through this system. And we were interested in a number of different questions. Can we create large graphs of the healthcare system by claims data? So the data set, this idea was started by a guy named Fred Trotter, who some of you may be familiar with, who initiated a Freedom of Information Act request to get the Center for Medicare Services, or CMS, to release data that would allow him to link providers to each other. So essentially, a set of edges where the edge weights were the number of shared patients between providers. Now, Fred's a reporter, and so he had some idea of how he wanted them to build the edges. You couldn't release patient data at that point, and because you didn't want to identify individual patients. So he gave them a description of an algorithm. Now, Medicare, since Fred's request, which they released data, he called it doc graph, and it created a bit of a splash. I know the Neo4j folks have worked with that data set a fair amount. But CMS never released the actual code for the algorithm that they used to create the graph. The graph was based on Fred's written description of how doctors should be connected. So we were very interested. We started exploring that data set and found a large number of anomalies. So for example, In each Medicare claim, there's a provider, there's an organization that they're associated with. They each have unique identifying numbers. The Medicare graph contains them all linked to each other. And there are dependencies between the providers and the organizations. Those aren't discriminated in the graph. So we were interested in building these networks using known algorithms. So the data set that we started with is a de-identified Medicare claims data set. It still requires an IRB, an authorization, because you could get down to unicity and identify individual patients by the combination of providers. The providers are not anonymous. So one of the other hats I wear is as a transplant nephrologist, a medical kidney doctor. I have a unique identifier. You can look me up on the National Provider and Plan Enumeration System, NPPES. You can download that whole data set. So that also comes with addresses and other attributes. So you know who the providers are if they're nodes. This data set is the actual bipartite claims data set. It's 180 million annual claims, 40 million patients, over 100 data elements per claim. The data is time-stamped, and it requires a HIPAA-compliant compute platform. HIPAA is the U.S. government patient confidentiality law. The reason it's relevant is that if you release, it's a $1,000 fine per individual, per instance of an individual's data that is released. So if you've got 180 million claims, so you need a restricted area where you can run your software on high performance computing and other folks can't get to it, and there are certain requirements for those systems. There's the national provider, that should be 2.2 million providers by 210 data elements. That data is messy, doesn't change very much. This is sort of the workflow for this, including what we would like to be doing. Take this bipartite claims data and associate it with providers, construct the networks. We've got GIS-coded addresses. I'll explain what this means in a minute. This is part of a network that we've created. Once we have geocoded addresses, we can associate provider groups with census tract data. We also have taxonomies. This part, the National Provider ID Index, is publicly available, and you could download it now without any issues. So we looked at 3 types of graph construction algorithms. Because of the size of the data set, matrix multiplication to transform a bipartite graph into a unipartite projection seemed quite unwieldy even as sparse matrices. This sliding window algorithm, first what you do is for each individual patient, you aggregate their claims. Claims are bills for encounters with a provider. You sort the claims by patient, and then you order the claims temporally. This is what, to our best ability, is a reconstruction of the algorithm that Medicare uses. We call it the sliding window. You start with patient sees provider A. This represents a claim. There's a frame or a window, and you create an edge to every other unique provider that is within that window, and then you shift to the next claim. And you do this. I don't understand what this algorithm means, but this appears to be what our government is using to produce this data. We constructed 2 other different algorithms. One is a binning algorithm, which within a window of some time period constructs a complete graph of all the providers that occurred during that time period. The individual edge weights then are tallied across the entire data set to give you edge weights of shared patients between providers. The dyad method is simply a trace route algorithm for constructing a network. We then constructed both provider-provider and organization-organization networks and compared some graph properties. The graph diameters, these were done on a PGX platform. The graph diameters for the methods differed quite a bit. The diameters for the binning method, which creates complete graphs, were the shortest. This is network assortivity, and we looked at mean clustering coefficients. The largest connected component, these are windows where we just took the entire data set. We didn't shift across the data set. So this is the largest set of graphs we could produce. These are the organization networks. We segregated these two. They tend to be very, very dense. They have very high edge weights because there are many fewer organizations than there are providers. So then we were interested in the properties of these. So why do people use different size windows, or what was the rationale for that? The idea was to look at whether a team of providers came together during a certain period of time to take care of an individual. And so we looked at the dependency of some very simple measures, the number of vertices that were present in the graph, or the number of edges. These are the three methods. Red is for the binning method. The dyad method is the orange, and the sliding method is in blue. Now, the other thing that Medicare does is, because of this issue of unicity and being able to identify an individual by the unique combination of providers, they censor the graphs. So if the edge weight between providers is less than 11, they eliminate it from the data that they release publicly. So we were interested in then the effect of censoring on these graphs and what it told us about the healthcare network. And you can see there's a profound reduction in the number, this is a log scale, in the number of vertices and number of edges that occur in each of these graphs. But when you look at graph density, it's even more substantial. And there's really a time dependency in terms of whether you capture the entire network. The most stable of these was the trace route mapping algorithm in terms of capturing the network properties. We also looked at the properties of the networks, whether these obeyed a power law, and we used the method of Clauset and Newman to fit to a variety of power law and other distributions. These are the cumulative distribution functions, and for the provider-to-provider networks, they could be fit with a power law distribution with a minimum. But for the organization-to-organization networks, these were best fit to a power law with an exponential cutoff. We think that some of this has to do with the regionality of these graphs. They're more like power companies in the sense that you would expect providers to be connected locally. You would expect some providers to be connected by patients that travel large distances. So for example, if you needed cancer care and you wanted to go to the MD Anderson or Fred Hutchinson or Mayo Clinic or other cancer centers in the country, you would fly a large distance, and those two providers might be connected. These graphs that I'm going to show you are a geographic layout because we geocoded providers, we could look at the geographically laid out distribution of edges between providers, and so this is interpretable. The actual physical distance between providers changes as I'm going to cycle through these graphs. So these are distances where people have sequentially seen one provider, and then the second provider that they saw next is less than 5 miles away. And this layout represents 250,000 edges. And what you see as you increase the distance between the healthcare providers that people traveled to are these star-shaped patterns. So these represent people traveling from rural areas back to larger cities where specialty care is available. Here's my favorite graph. So this is the Northeast. These are all the people that winter in Florida. So they saw their doctor before they left for Florida, and then they saw a provider in Florida. You'll notice on the West Coast that people travel up and down the coast, but nobody winters in Florida. And these are people who are traveling across the country or from Hawaii, Alaska, and other areas. Because we had geospatial information, we could see that that for the provider dyads, this is teaming visits. Most of them had a small number of visits. So when you talk about physicians acting as groups, most of them share less than 50 patients by this sequential method. And why is this relevant? This is Medicare spending, so from the data that I just showed you. This is private insurance. You can see that there are very different spending patterns across the country. We have financial data for these visits, so we can look at the groups that account for large amounts of cost, and our goal is to associate this with outcomes. So my wish list for this group, we're really, really interested in routines for constructing time-varying graphs, as well as community identification methods that work on these moderate to fairly large-sized graphs to identify groups of providers that share patients by choice. This is the software we used for most of these analytics, and my team. Thank you very much. Happy to take questions.
Who do you think is going to be happier with your research? Insurance companies or hospitals?
I think it depends on, so insurance companies or hospitals, that's an interesting question. Well, this is the government insurance company.
Yes.
So in terms of potential users, the United States now consists of cantons of insurance risk, meaning that we have organizations that get insurance premiums from, say, 1 million people, and they're competing with each other in that they want their patients to see providers who are within the network so they can keep whatever the money they get, and they don't want them to see providers in other networks. But they want to attract providers from those other networks. It's called leakage analysis. This kind of thing will allow insurance companies to essentially compete against each other.
On the other hand, the patterns
Yep.
detect people who may not be very, insurance companies might not like, right? These
recurring patterns?
Oh, well, the hospitals are going to like this because the hospital models. The reason is that, the goal of this is to improve outcomes, reduce length of stay, and identify patterns where people are going to get sicker so that you can prevent that. All of those complications are expensive. So the more you can identify risks based on patterns, the better off your patients will be, and the lower the cost of healthcare.
Any other questions?
I was just curious, when you, in the last map of the U.S., you had things going outside?
Yeah.
So where is that going? I thought you were just U.S. things.
Well, Alaska.
No, but you had Alaska and Hawaii. It seemed that you had something going southeast.
Southeast. So,
I mean,
Puerto Rico.
Oh, Puerto Rico, bro?
Yeah.
Okay, thank you.
Thank you.